dose with the atropine ointment. Here, post-op antifungal management was started. Topical steroid was started after 2 weeks as there was no recurrence and neither infiltrate was there. On 2 months post-op, vision was 612, not improving further due to cataract. After 6 months, cataract surgery was performed. Post-cataract surgery, the vision is 6/6 part. The surgical pulse are here, refine 0.5 mm beyond the infiltrated cornea to eradicate the infective focus. After removing host corneal butter, remove the exudates and open the angles with the viscoelastic substance. Make 2 to 3 peripheral iridectomies. Cut the ledges as they can act as a source of recurrence due to residual infiltrate. After taking cardinal sutures, use BSS. Sutures to be taken if leak is found. Post-op antifungal or antibacterial to be started as per microbiology report of scraping. If there is no recurrence or infiltration found after 2 weeks post-op, topical steroid should be started.
Any questions? Judges? Shall we move ahead?
Yeah.
Thank you, Ritik. Yes. Sure. Okay. Have you uploaded your presentation?
You are Dr. Mohammed.
Do we have Dr. Shivani Patnaik here? Dr. Kiran Deep? You there? Okay. Dr. Bharat?
Only one presenter. He is Dr.
Can we
Sefsan
start?
Muhammad, no? You are?
Shefsan Mohammed, yes
Shefsan
ma'am.
Mohammed.
Yes ma'am.
They'll be coming later? Okay.
So I'll be explaining how we corrected surgically corrected a case of esotropia. So initially we have given 2 conjunctival stay sutures, and then the medial rectus is exposed, and then it is held with the help of a muscle hook. Then the medial rectus muscle is basically tied with the help of Wicknot sutures so that it doesn't slip once the medial rectus is cut. We are planning a medial rectus recession and a lateral rectus resection for esotropia. So here the medial rectus muscle is cut. The medial rectus recession is being done over here. A 4.5 millimeter distance is measured from the insertion point, and now the medial rectus is sutured to the sclera. And as you can see, because we have given the Wicknot sutures, the muscle doesn't slip away. That is the main point of the Wicknot sutures. The surgeon basically sits towards the temporal side so that the medial rectus could be visualized. Now the surgeon changes the position towards the opposite side so that the lateral rectus can be visualized. And now again a conjunctival peritomy is done. The lateral rectus is visualized and held with the help of a muscle hook. A 7 millimeter distance is measured from the insertion point. And just like how we did for the medial rectus, the Wicknot sutures are being given to the lateral rectus also. And once that is done, the lateral rectus is resected. The muscle is cut. The medial rectus was resected, so this incision was given, but here part of the muscle is cut, and then it is again sutured back to the insertion point of the lateral rectus. And after that, a continuous stay suture is done, and subconch gentamicin, dexamethasone, and atropine is given. So post-operatively, initially before the surgery, Hirschberg test about 15 degrees was there. Post-operatively, we have a complete vision of, the Hirschberg test was 0 degrees in both the eyes. Thank you. That's it.
That's all? Video is too shaky.
You don't have video post-op.
So actually, sir just said we had to give the video, so I.
Fine.
So the pictures this can be incorporated in the video. Yeah.
Okay, ma'am. Yes,
Yeah,
ma'am.
yeah, right.
Yes, yes, ma'am. With the exoplane.
Thank you.
Thank you, ma'am.
Dr. Bharat, please come.
Good afternoon, respected judges.
Role of AI in corneal disorders and refractive surgery. Bharat Garnani, Kirandeep Kaur.
Sound?
Refractive errors and corneal diseases are the primary global causes of blindness. AI is disease. Role of AI in corneal disorders and refractive surgery. Bharat Garnani, Kirandeep Kaur. Refractive errors and corneal diseases are the primary global causes of blindness. AI is reshaping patient care, making it more accurate and personalized. Let's explore the era of AI in corneal disorders and refractive surgery. The demand for perfect vision is increasing the number of cornea or lens-based refractive surgeries. With advancements in AI technologies, researchers and clinicians are now focusing on the less explored areas related to the eye's anterior segment. Slit lamp photography, anterior segment optical coherence tomography, corneal tomography, in vivo confocal microscopy, and optical biometers are frequently used to study various corneal conditions. These conditions encompass infectious keratitis, keratoconus, corneal grafts, ocular surface issues, pre-surgery evaluations for vision correction, calculations for intraocular lenses, and automated refraction. Before embarking onto the disorders, let's understand few basic principles of artificial intelligence. AI is engineered to emulate human actions and make decisions reminiscent of human judgment through sophisticated coding. In recent times, the popularity of machine learning techniques has surged. These ML methods use sample training data to create models, such as logistic regression, artificial neural networks, and decision trees, allowing them to make predictions or decisions without specific programming. Deep learning is a specialized branch of machine learning that has proven to excel in various domains. By autonomously identifying hierarchical features, DL algorithms enable intricate relationships between input data and decision-making outcomes. The foundational concept of the convolutional neural network, coupled with a significant technological advancement enabling the training of deeper neural networks, deep CNNs have set new standards in numerous image-related tasks such as object recognition, image segmentation, and disease classification. Model training is deeply influenced by the caliber of the training dataset. Especially in medical contexts, clinicians often enhance the data quality by offering detailed annotations, whether they're at the pixel or image level, or even a combination of both. AI has effectively been applied to predict diagnoses for a range of corneal disorders, such as infectious keratitis, keratoconus, pterygium, endothelial conditions, and complications related to corneal grafts. Detecting early stages of form frustae keratoconus or potential keratoconus, particularly prior to refractive surgeries, continues to pose a clinical hurdle. AI has demonstrated its efficacy in identifying corneal ectasia, including keratoconus. AI-powered tools have enabled us to remotely monitor patients, thus augmenting their care and minimizing hospital visits. October images have been utilized to distinguish between normal corneas and edematous corneas using algorithms based on deep learning techniques. There has been an increased clinical interest in the use of in vivo confocal microscopic images to analyze subbasal nerve plexus features and correlate them with ocular and systemic diseases. Utilizing deep learning algorithms for the complete automation of analyzing corneal endothelium parameters through specular microscopy in eyes that have received ultra-thin Decimé stripping automated endothelial keratoplasty, DSEK. AI-assisted analysis of data obtained from Scheimpflug imaging has been shown to predict the need for penetrating and lamellar keratoplasty. Artificial intelligence in refractive surgery. The use of AI in screening prior to refractive surgeries is crucial for identifying individuals at a high risk of iatrogenic ectasia. This is achieved through the utilization of the Pentacam Random Forest Index, PRFI, a machine learning algorithm trained on random forest, RF, data. AI has been utilized to suggest suitable refractive surgery procedures and the accompanying nomograms. Deep learning has been employed to predict refractive errors using imaging analysis, such as fundus images. The Visual Behavior Monitor is an innovative wearable device designed to accurately assess the visual behaviors of patients before surgery. This information helps determine the best course of action for refractive correction interventions. The monitor used machine learning algorithms to evaluate data sent to the cloud and analyze patterns in lifestyle, such as the type of lighting used, reading distances, how long reading or other tasks were done. Adhering to research, governmental regulations, and predicting future trends will be crucial for realizing AI's full potential in ophthalmology. There has been a paradigm shift, where technology and medicine converge to foster a future where eye care becomes more precise and accessible. It's a comprehensive guide for professionals eager to understand and harness the power of AI. Hence, the integration of artificial intelligence in managing corneal and refractive disorders is reshaping patient care, making it more accurate and personalized. The acknowledgement of the worldwide impact of corneal diseases and refractive issues has brought attention to the lack of sufficient screening for these conditions, particularly in countries with limited resources. With advancements in anterior segment disease, it is probable that both imaging and non-imaging based AI algorithms could facilitate prompt diagnosis and treatment of corneal diseases, as well as progress in refractive surgery. With deep learning models, we've been able to diagnose conditions with unprecedented accuracy, reducing human errors significantly. By leveraging AI analysis, we have been able to tailor procedures to individual needs, ensuring more predictable and efficient results. AI's ability to predict corneal complications and streamline refractive care is enhancing recovery paths. By now, we can say that the tangible benefits of AI integration in corneal disorders are beyond words. With AI integration, accuracy is enhanced, personalized plans are facilitated, and patient care is augmented. The research, case studies, and first-hand insights underscore AI's positive impact, but we must also be mindful of ethical considerations and potential limitations.
Okay, this one is not working.
Automated diagnosis is transforming the way we identify intricate corneal patterns and refractive anomalies, and in future will facilitate diagnosis and treatment armamentarium of clinicians.
Is this the original video made by you?
Yes, ma'am.
Which tool did you use?
I use ma'am AI-based tool Pictree. Yes, ma'am.
Dr. Bharat, I have just one question.
Yes,
You
ma'am.
made this presentation using AI-based tool. Is there no provision for using Indian characters and most importantly an Indian voiceover with an Indian accent, an Indian pronunciation and an Indian diction?
Yes.
Because you have to understand that sometimes the audience and maybe even the judges are not able to follow a diction that's not familiar.
Okay.
So is there any provision? That's what I mean. I don't use AI. So
Yes, ma'am. You can do it based on like there are voiceovers where you can use Indian voice also.
Why did you choose this monotonous performance?
Yeah. You could
Like-
have given
not
your
very
voice.
catchy.
Next time and
That would
take
have
care.
been much better
Yes,
and
ma'am.
much appreciated.
Sure.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Can we have Dr. Kiran next?
Role of AI in pediatric ophthalmology.
Good afternoon, all the judges.
Is the same tool you have used?
Yes, ma'am.
Similar kind of presentation?
Yes, ma'am.
Role of AI in Pediatric Ophthalmology by Kirandeep Kaur Bharat Gurnani. The growing accessibility of ophthalmic data, combined with progress in artificial intelligence and machine learning, holds the promise to revolutionize clinical practice. Machine learning methods, when applied to general ophthalmology, have shown promising capabilities in areas such as automatic disease identification, preliminary screening of primary care patients for specialist consultations, and contributing to scientific research. Serving alongside ophthalmologists, these and upcoming applications hold the promise to enhance patient care, cut down expenses and access hurdles, minimize unwarranted referrals, allow for consistent monitoring, and facilitate early identification of diseases. Special considerations in pediatric eye care. The prevalence, causes, symptoms, diagnosis, and treatment of eye diseases vary significantly between adults and children. These differences are crucial to take into account when designing artificial intelligence applications. Children often experience conditions such as amblyopia, strabismus, blocked tear ducts, also known as NLDO, ROP, and inherited eye disorders. Glaucoma serves as a prime example since the origin and symptoms in congenital glaucoma patients differ significantly from those with adult-onset glaucoma. Retinopathy of prematurity. In the field of pediatric ophthalmology, the most notable AI advancements relate to ROP, a major cause of childhood blindness globally. Initial efforts to detect plus disease in fundus photos centered on the measurement of vessel tortuosity. One pioneering method sought to measure tortuosity through the spatial frequency of hand-drawn vessel traces. Since that time, multiple tools like Vessel Finder, VesselMap, ROPTool, RISA, CAIAR, and IVAN have been introduced. However, newer techniques for identifying ROP and plus disease predominantly utilize convolutional neural networks, CNNs. Systems such as those by Wuerl et al., IROPDL, and DeepROP employ this approach. These CNN-based methods analyze fundus photos directly, eliminating the need for manual annotations. Improvisation potential. While existing ROP detection techniques can differentiate between severe and mild ROP, they don't provide detailed insights into the disease's stage or zone. Only systems like DeepROP and MeGraph consider more than the posterior pole view, with others either neglecting or purposefully omitting alternative views. Even though research indicates that severe conditions rarely occur without posterior pole vasculature changes, offering a more comprehensive breakdown of the disease's zone and stage might enhance the system's clarity and effectiveness. Insights into pediatric cataract. Cataracts in children are more varied than in adults, influencing the decision to surgically remove them based on their severity and the risk of vision impairment. The CC Cruiser is a cloud software that can identify cataracts from specialized eye images, classify them, and suggest possible treatments. It first adjusts the image to focus on the lens, and then utilizes 3 distinct convolutional neural networks, based on modified AlexNets, to determine if a cataract is present, grade its characteristics, and advise on treatment. When tested in a comprehensive study across 5 eye care clinics, CC Cruiser's accuracy in detecting cataracts and suggesting treatments was 87.4% and 70.8%, respectively, which is lower than human experts who scored 99.1% and 96.7%. Insights into strabismus. Strabismus affects 1 in 50 children and can cause amblyopia, interfere with binocularity, and have lasting psychosocial effects. A CNN was used to detect strabismus based on visual manifestation in the eye regions of facial photos, which would be especially useful for telemedical evaluation. For in-office evaluation, which in contrast permits the use of specialized screening instruments, strabismus can be detected using a CNN based on fixation deviations from eye tracking data or with very high sensitivity and specificity from retinal birefringence scanning. Insights into vision screening. Strabismus and refractive error can both lead to amblyopia, and unfortunately, they're not easily detected by pediatricians. To address this, experts recommend instrument-based vision screenings. Most of these instruments can be adjusted for signaling when there's a potential issue. Van Eenwyk and colleagues utilized video frames from a device that merges Bruckner pupil red reflex imaging with eccentric photorefraction. They trained several machine learning models to identify risk factors for amblyopia in young kids. Of these, the C4.5 decision tree stood out as the most effective. Insights into myopia. High myopia can lead to severe vision problems. To prevent or slow down its progression, children who are susceptible to high myopia can be given low-dose atropine. However, deciding which children should receive this treatment can be challenging. A study by Lin et al. Used a random forest to forecast high myopia in children based on clinical data, providing reliable predictions for as long as 8 years ahead. Continued research in this area may assist in guiding preventive treatments. As AI becomes essential in pediatric eye care, it's crucial to address ethical concerns, data protection, and the clarity of algorithms. It's imperative for AI creators, ophthalmologists, pediatricians, and regulatory agencies to work together to guarantee the safe and conscientious implementation of AI solution. By refining early detection processes, boosting diagnostic precision, and tailoring treatment plans, AI is reshaping how we approach children's ophthalmology. As we journey through this promising era, harmonizing human skill with AI advancements is essential to ensure a more promising future for young individuals facing visual difficulties.
So Kiran, in simple words, how can you incorporate AI tool in your regular day-to-day practice in India?
Ma'am, the most important issue is when we are talking about mass screening, we need AI to do it because we don't have the sufficient number of personnels to actually go and screen when we are talking about the schools in the rural regions. So the use of AI, it has helped, like especially in ROP when we are doing the telescreening, and in amblyopia screening when we are there are a lot of children who are having an underlying refractive errors which are left often undetected up to later ages. So with the help of different photo screeners which are based upon the databases, and then AI based programs have been incorporated into these. So these are useful in screening in the rural areas as well, wherein the children, they are not having an access to the pediatric ophthalmologist, and their underlying conditions can often be misdiagnosed.
So who's going to operate these?
So ma'am, I did one study in which we used a photo screener to do mass screening in over 1 lakh children. So we trained a bus driver, of our tertiary eye care hospital only. A bus driver was trained to do the screening, and all the children who were given pass, it gives results in the form of pass, inconclusive, and refer. So pass means we can reliably say that the children are assumingly to be normal, and refer means the machine has not been able to detect, either there is a strabismus or underlying high myopia that is significant enough to cause amblyopia. So those children were given refer. And inconclusive was wherein at times the child would not have cooperated, or either the machine is not able to detect clearly whether it is pass or refer. So then what we did is all the inconclusive and the refer children, they were collectively we collaborated with the different schools with the help of district health programs, and then they were screened by doctors. So this reduced the workload of doctors a lot, because instead of screening 1 lakh, it was only close to 10,000 children that you have to screen. So that load of 90,000 that is getting off is a big thing, where AI can play a role. So I have published the preliminary data of this. It was published in Indian Journal of Ophthalmology only. So the sensitivity and specificity definitely, as I stated in the video also, it is less than the humans. So there is always a risk that there might be a small percentage of children who might be given a pass criteria, but
How
actually,
small is it? How small or big is it?
the age criteria, it was 87.6% sensitivity, and specificity was 86.8%. But this is definitely lesser than the human, what they can do. But this can help us in reaching to the unreached. That is the main aim, wherein we can incorporate AI.
Yes.
Thank you. Thank you.
So do we have Dr. Shivani here right now? Yes. Dr. Nimrit, Arnav.
My voiceover is also there.
it is a soft cataract. A new tip is being used, so it is easily cheesing away the material. The vacuum is high. The vacuum setting should have been lowered, and we are not embedding the tip into the material well. Now, moving on. Next, we have certain steps that we see in the video. So, what happens is, we try to small pieces were coming off, but the heartbeat was racing because at this point the nucleus was pretty much bare and the epinucleus was showing up. Still, in order to finish the case, there was a point of hurry where the PC was something that one should not do. There is a point where we are trying to search for another place where we can latch onto the nucleus and bring it out. And eventually all these attempts led us to thinking that maybe increasing the size of the rexus would help. Increasing the size of the rexus at this point, we tried to express the nucleus out by lifting it with viscoelastic, but that extended the tear further and the nucleus worked. So we involved the surgeon which is hook versus ring. Now with a hook, what we get is increased exposure. With a ring, we'll get a limited exposure. Pupil viscodilation only lasts till the viscoelastic is still there in the AC. You can continue to struggle, but you know where it has landed us before. And if hooks, how to place the hooks, that is very important. And the epinuclear plate is then removed and the IOL is safely placed inside the bag without any complications. When the hooks are removed, the suture is put to ensure, because this was a floppy iris, and we avoided all the complications which had occurred the previous day. So even whether it is a novice surgeon or an experienced surgeon, it's better to learn from previous mistakes and apply them in the case so that you can avoid further mistakes. Thank you.
So Shivani,
Good.
with a 5.5 millimeter of pupil for the second case,
Yes, ma'am.
do you think a hook should have been used before, you proceeded? Because you placed the hooks after.
Yeah, the pupil expander should have been used before, because the crater started being formed. That is when I thought of using the pupil expanders. Yes, using it
Was
before.
done by you?
Yeah, yes.
And what did you learn from the first case?
From the first case, I learned that I should not dig in with my phaco probe. I should wait and assess the situation. Every step in phaco is important because one small incision can lead to the downfall of the entire case. So starting from the leaking side port to the small incision to the small rexus, everything played a role in making that case go wrong.
On a lighter note, Shivani, if you had to give one caption to this presentation, what would it be? Perhaps a non-scientific caption.
I would call it the domino effect. It has led
I
from
would say
one.
once bitten, twice shy.
That's true. Thank you, ma'am.
Thank you.
Thank you.
Thank you. Next is Dr. Prasanna.
Somewhere. Okay.
Dr. Prasanna Venkatas.
We'll come.
Arnav, this one, no? Nimrita is not here. You are, okay.
If you have a blurred image during surgery, what would you do?
Rub my eyes to have a clearer vision.
I will ask my assistant to probably clean the microscope lenses.
Change the microscope bulb.
I would dim the OR lights.
I would probably scrape the cornea. I would refer to an expert surgeon.
Endo-illuminator, machine made simple. The surgical approach in eyes with poor visualization is highly challenging. When visualization of intraocular structures seems inadequate under the operating microscope, a simple modification in the surgical procedure by having an endo-illuminator can be the game changer. Endo-illuminator works on the principle of oblique illumination, wherein the eye is directly seen under the microscope with the light of the microscope switched off and the endo-illuminator being held at an angle of more than 70 degrees externally along the limbus to illuminate the anterior segment structures. It improves visualization by providing a stable, stationary, and diffused form of illumination. The illumination is based on a wide-angle approach resulting in low irradiance. Intracameral endo-illumination reduces the light scatter and glare, maximizing corneal transparency and allowing safe and effective surgery. Since 1993, use of endo-illuminator has been described for cataract surgery for visualizing the anterior capsular flap in hypermature cataracts, endo-illumination guided irrigation and aspiration during combined 23-gauge sutureless vitrectomy, as well as endo-illuminated infusion cannula for bimanual anterior chamber vitrectomy has also been described. Handheld fibers exhibit smaller illumination angles. However, they are more focused. Current illumination systems consist of high-intensity light sources and single-use endo-illumination fibers up to 30 G. Existing devices employ xenon, halogen, mercury vapor lamps, or light-emitting diodes, LEDs, as light sources. Commercial systems available from Synergetics, Alcon Laboratories, or DORC. Use of endo-illuminator is described sparingly in anterior segment surgeries. During anterior segment surgeries complicated by hazy media, endo-illuminator acts as an external light source, enhancing visibility of the operating surgeon, aiding in smooth performance, achieving better surgical outcome. Here, we describe a series of challenging surgical scenarios in which the technique of endo-illuminator assisted surgery was performed with ease. The first case is of scarred cornea, in which visualization of the anterior chamber and beyond was arduous. Even after debriding the epithelium, coaxial light of the microscope doesn't help much in visualization. This is where the endo-illuminator comes to the rescue. It helps to visualize and implant a glued IOL. The next scenario is that of a post-traumatic cataract with iridodialysis. The endo-illuminator helps us in visualization of the remnant iris while we use the piecemeal technique in different areas to refix the iridodialysis. It also aids in better visualization of the vitreous strands when dye is not used. Furthermore, it helps while passing the 9-0 needle through the iris during single-pass 4-throw pupilloplasty and cutting of sutures post-SFT. In the next case scenario of a failed PK graft, the role of endo-illuminator is substantial, as the opaque failed graft doesn't allow any coaxial light of the microscope to pass through, and endo-illuminator helps in visualizing structures underneath. The endo-illuminator also aids in the formation of Purkinje images, which guides the centration of the pupil post-pinhole pupilloplasty using the single-pass 4-throw technique. In this interesting case of an ACIOL with summering ring in which the haptics were stuck in the anterior chamber angles, Endo-Illuminator assists in visualization and creating surgical iridectomy to release the haptic, and also while burping out the summering ring out of the AC and vitrectomy. In this case of glued IOL, where the haptic of 3-piece IOL broke, Endo-Illuminator comes to the rescue and helps in finding the broken end of haptic and safely explanting the haptic and damaged 3-piece IOL out of the eye. The view of the PDEC graft is enhanced when the Endo-Illuminator light is added to the field. When we put off the microscope light and just use the Endo-Illuminator light at an oblique angle, it gives beautiful illumination and excellent depth perception. The comprehension by the surgeon of the graft orientation and the graft dynamics within the anterior chamber is much better, and the direction of the graft can be easily made out. The unfolding of the graft can also be carried out with just the Endo-Illuminator light alone, and this gives a very good clarity to the surgeon, as you can see here, as opposed to the microscope light, where it is very difficult to make out whether the graft is facing upwards or downwards. You can see here the visualization is improved as compared to a very poor understanding of the graft with the microscope light alone. In case of inadvertent trauma to the Descemet's membrane, it can cause Descemet's membrane detachment, which might be very small and can get unnoticed, causing long-term corneal edema. Endo-Illuminator light, when falls at an angle, can help in the visualization of these small breaks in DM. Vitrectomy endo-illumination attachments are often available, which allow aspiration infusion and vitrectomy. Apart from the above scenarios, it can be used in cases of trauma, chronic degenerative changes such as Labrador keratopathy, bullous keratopathy, corneal dystrophies, PPP, glued IOL, surgical iridotomy. Endothelial contact should be carefully avoided throughout and positioned inferotemporally and supported by the assistant. The endo-illumination probe should not physically interfere with microsurgical manipulation within the AC. The Endo-Illuminator aided modified approach to such cases is highly feasible, practical and convenient. It can serve as a smart addition to our surgical armamentarium, as patients with concomitant pathology can still get good post-operative vision with this modified technique, helping achieve better results both intra and post-operatively.
Thank you. Thank you.
Good. All those videos were original.
Yes, ma'am. Yes, ma'am. Few done by me and few by other surgeons. Yes.
Artificial.
Please, Dr. Prasanna. Yeah, Dr. Prasanna.
Yes, ma'am.
Artificial Intelligence in Glaucoma, the novel, self-built, cost-effective and multimodal AI toolbox. No financial interest. We have heard about artificial intelligence and augmented reality working together. Is it just the hype or the real McCoy? Yes. It is real and is happening. This has revolutionized our lifestyle. Day-to-day activities that include the 2D or 3D face recognition tool used to unlock our mobile phone, fingerprint, iris scanner, etc. Unmanned robotic car with spatial recognition is another example. This technology also uses LiDAR sensor, ultrasonic sensor, camera, and radar sensor to visualize its surroundings and act accordingly. NASA's first large unmanned aircraft flight was also launched using artificial intelligence. Artificial intelligence performs much better than human beings in the image recognition field. Glaucoma is an image recognition field, which uses fundus photography, optical coherence tomography, etc. The artificial intelligence algorithm created by us uses a neural framework similar to the neural network in the human body. The artificial intelligence algorithm has to undergo the growth process similar to a human. We have used the medical image annotation tool called the Visual Object Tagging Tool, VOTT. The first step is annotation. which is the action of marking a text or diagram. Previous studies didn't clearly explain the black box dilemma. A question was raised: what is inside the black box of artificial intelligence? The rationale behind the predictions of AI are not clearly understood. This is how our AI is trained. Fundus images are collected randomly and then it goes through the annotation process using the VOTT annotation tool. Further, it goes into the annotation dataset, then into the SANS-10 AI toolbox where the AI makes its prediction, which is in turn validated by humans. The incorrect predictions go back to the annotation step and the process is repeated. This is the annotation process in which the disk is marked and annotated. Similarly, the normal macula, normal vessels, glaucomatous cupping, RNFL wedge defect, bayoneting sign, disc hemorrhage, peripapillary atrophy, tilted disc, etc. This is the final output after the complete annotations. Intersection over union, objectness loss, and classification loss showed better results after each test, with improvement in precision, recall, and minimum average precision values. These are some of the predictions made by our AI tool, predicting not only the diagnosis, but also the intrinsic signs, thus making it an explainable AI. We have worked on an explainable AI model and evaluated its interpretability. Sensitivity is 96.4% and specificity is 100%. In this research, we have utilized TrueColor confocal fundus photography, which yields good quality high-resolution images, thus improving the interpretability. We have also explored the application of artificial intelligence in angle assessment, which gave better results using multimodal imaging techniques. Here is the schematic plan of how the AI assesses the angle. This flowchart illustrates the process of angle annotation. The scleral spur, which is the thickest part of the sclera, is designated with a yellow mark. The trabecular meshwork, which is marked as green, is located 500 micrometers from the scleral spur. The iris point is the location on the iris, where the perpendicular drawn from the trabecular meshwork meets. The apex is where the cornea and iris converge. A line is drawn from the apex to the point on the iris and trabecular meshwork, which forms the angle. A protractor is used to measure the angle. An angle less than 15 degrees is regarded as narrow, whereas more than 15 degrees is considered open. Closed angle refers to an extremely small angle. The final annotation of the angle is done using the bounding box tool. We aim for multimodal angle annotation using artificial intelligence. Final angle annotation done in a UBM image. Angle annotation done in Anterion image. Angle annotation done in an ASOCT image. Angle annotation done in SchemeFlug image. After several training process, the AI model attained growth. Artificial intelligence and augmented reality can be incorporated for simulative glaucoma learning. We have innovated a software named IMG Holo in Microsoft HoloLens for simulative learning, teaching, counseling, and diagnostics. In this video on the right-hand side, you can see the person using the HoloLens, moving his hand in thin air, and the left-hand side part of the video shows what he actually sees through the HoloLens. The eyeball model created by us using a real fundus image with splinter hemorrhage is being demonstrated. The user can rotate and zoom the model accordingly. Similarly, the angle structure can be viewed. Also, there are models showing the RNFL defect. Practicing in the ophthalmic metaverse. The novel, self-built 3D simulator. With the use of hand tracking in the HoloLens, a simulative training module is created. The 3D eyeball model gives a real-time simulation of the angle structures to practice the implantation of the eye stent. During the simulated training, on proper implantation of the eye stent into the trabecular meshwork, the indicator lights up as green. This training improves the agility of the doctor for the implantation of the eye stent in the angle. During the inception of AI or AR, the expectation is similar to arm wrestling between doctors and AI. But the reality is that doctors and artificial intelligence need to work together for a better humanity, where AI helps in screening and the final diagnosis is done by the doctor, thereby increasing awareness among the community and helping in treating and curing the human population. Our novel, self-built, innovative AI tool workflow in glaucoma diagnostics. The imaging done using the image capture devices goes through our AI software, and then within 60 seconds, with no chair time, the glaucoma diagnosis and interpretation is done. Artificial intelligence and augmented reality are the future of e-ophthalmology. Thank you.
Very innovative, Prasanna, as usual.
Thank you, ma'am.
So I just have one question.
Yes, ma'am.
When you're training the surgeons, like I think the later half of your video you
Yes,
showed
ma'am.
about. So do you think just doing AI and then the patient and the surgeon can operate? Does he need a practical guidance as well?
Ma'am, the concept of AI, according to me, is having human intelligence along with artificial intelligence. So the artificial intelligence has to have a human in the loop training. It's called HITL, human in the loop. So keeping humans in the loop, the humans will always be able to be on top as well as collaborate with the AI. So that will create an explainable AI. Because if we go for a generative AI, then the humans will not be able to control, and it may become a rogue AI or an erratic one. And another thing is, I would like to use a metaphor there. So I would always want to fly in a plane where there are two manual pilots as well. I would not like to fly in a plane where it's completely automated. So there is a role for humans as well, similar to the surgical training that you asked. The simulations and the modulations can be given in AR as well as in AI, but that helps them in accelerating towards their hand-eye coordination and developing their fine motor skills when they are a neophyte. But that's not it's not a substitute, ma'am. It's just going to accelerate their learning if it's surgical simulations.
Like it will be an add-on rather than a substitute.
Ma'am, I am not able to hear it, ma'am.
It will be add-on, like helping
Yes,
the
ma'am. It's a add-on, and even
not
in
a
the
substitute.
Not a substitute. And even in the diagnostics part, we have kept two layers in the algorithm. One is human annotation. So if you see the fundus images, the humans, being the glaucomatologist, annotated the RNFL defect, annotated the bionetting sign or the vertical cup disc ratio. So it's like teaching a baby how to pick up a finding. And again, the predictions again will be evaluated by the humans, but this process will be immediately done because we have coded it in that way. Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you.
So we have the last video by Dr. Nimrita.
A deep cut trabeculectomy triangular flap rescued by micro-invasive glaucoma surgery GAT. Trabeculectomy is considered gold standard technique, but it has less standardized technique, complication in up to 40%, failure in up to 50% at 5 years, and cataract in 50% at 5 years. Some of the common intraoperative complications by trabeculectomy are conjunctival buttonholing, flap disc insertion, deep cut, thin flaps, and micro leaks. The nightmares of trap goes on and on and on. A 60-year-old female patient presented in glaucoma OPD with diagnosis of primary open-angle glaucoma. Patient was on maximum medical anti-glaucoma medication for right eye with advanced disc damage and monotherapy for left eye. Trabeculectomy was planned for right eye. Intraoperatively, while raising triangular flap, a deep flap cut was made accidentally. Now what? There are array of mixed procedures and GATT is one of the most safest and economical procedure for glaucoma management. What is GATT? It is gonioscopy assisted transilluminate trabeculectomy, in which trabecular meshwork is circumferentially bypassed using fibroproline suture or a catheter. Finally, GATT was planned for the patient on table. Phacoemulsification was done. 1.6% high density viscoelastic was injected in AC and over the cornea. Swan-Jacob gonio lens was placed after adjusting the microscope and patient position. A goniotomy of 1 to 2 mm is made in the nasal angle using MBR blade. A fibroproline suture blunted thermally using a low temperature cautery was threaded along the circumference of the Schlem's canal until the distal tip emerges through the goniotomy site, and the suture is then externalized, thereby circumnavigating 360-degree trabeculectomy. Sclerocorneal tunnel was made with crescent knife. Then AC entry was done using keratome. 3-piece intraocular lens was implanted in the bag. And the apical suture was taken with tenno nylon. Watertight conjunctival closure was done with tenno-vicryl suture. According to the literature, GATT has shown promising outcomes in various types of glaucoma management. To conclude, GATT is a versatile, efficient, safe, and most economic procedure.
Nice surgery, Nimrita. I wanted to ask you, why was GATT, phaco with GATT not planned as the primary procedure?
Ma'am, actually this was a CAM patient, and the operating surgeon was one fellow. So then it was eventually managed by
No,
senior
ideally,
glaucoma.
see, if there is a problem with the flap, you actually change the position of the surgery, right? You replan the surgery.
No,
Surgical
but-
site, you change the surgical site if it's a deep.
A deep cut.
Yeah.
But since the patient was having advanced glaucoma, so we planned to perform glaucoma filtration surgery in the form of mix, and then we implanted
What was the
BMM lens.
presenting IOP?
Presenting IOP, right eye was 24 on MMT with advanced disc cupping, and left eye was 14 mmHg and
Surgery was
moderate.
for the right eye, right?
Yes, yes, ma'am. Yes, ma'am.
So do you think GATT is a permanent procedure? Will it, usually MIGS is supposed to be a temporizing surgery, isn't it?
No, ma'am. Even the recent literature for 4-year outcome also for open angle glaucoma, it has shown
It's
good.
working.
Yeah, it's working. So I think so. It is
Because in a
very
CAM patient
efficient.
especially, you don't know how good the follow-up would be.
Yeah, but
So-
the advantage for performing mix is requires very less follow-up comparatively to TRAB. So less frequent follow-up and fast recovery also. So
No, you're talking just
patient-
about the immediate post-op. I'm talking about long-term follow-ups.
Uh,
What if the pressure starts increasing and you wouldn't know, basically? No?
Yeah, but the literature is supporting. It's a versatile procedure and the literature is there.
Why you decided to give a 3-piece lens?
That's
Ma'am,
a
actually
campaign.
Just because a
It's
cam
campaign.
case? Okay.
Yeah.
Yeah. Okay. Thank you. Nice.
Thank you, thank you.
ma'am.
Thank you, very nice presentations by everyone. We'll just have a quick
Yeah.
photograph. Come.